So we were talking about the cortex and the medullary cavity. So let me recall once again. So the cortex is the white dense area that is present down on the outer edges of the bone. Okay. And the less dense structure that is present down in the center of the bone is actually called as the medullary cavity, which is actually the cancellous bone. And you have to understand that the cortex density may be different in different parts of the bone when it is actually going either upwards or proximal to the bones, or when you are going down distal to the distal of the bones. Okay. Now the condition, what you need to understand here, one thing is that the different parts of the bone, actually the surface that is actually formed outside of the bone is actually called as the epiphysis. Okay, that is present down completely at the edges of the bone. Okay, wherever there are joints, okay, at the rear, the location of the joints, it is actually the epiphysis. And immediately down to it there is a spongy bone, which is the component that is actually called as the metaphysis. Okay, so the epiphysis. Okay, and you can see a line that is actually formed. This one is actually called as the epiphyseal plate. Okay, and then here you can actually see that there is a junction of the epiphysis. When it is converting down into the metaphysis, there is a line that is present down in between them, which is actually called as the epiphyseal line. Okay, so different parts of the bone has got different areas of the epiphysis and the metaphysis as well. Okay, so that is what you need to remember here. And all of them actually are forming down the medullary cavity itself. They are being redirected down and coming down into the medullary cavity itself. But the structure of this medullary cavity, the structure of the epiphysis, the structure of the metaphysis differs in different bones. Okay, so that is what you need to understand. It actually dependent upon its the stress that is actually taken up by the bone when actually trying to do the mechanical function of the appendicular skeleton. Where so depending upon the weight of your body, depending upon the stress that is taken by a bone in that particular region, actually is the one that determines the contents of the medullary cavity. Okay, or the composition or the compactness of the medullary cavity. All right, so that is what you need to understand here. Now, when it is compared down to the conventional radiograph, actually, yes, X-rays are the one that are frequently prescribed. Conventional radiography is a frequent investigation that is actually prescribed down for the evaluation of bones. But you have to also understand one thing, that CT and MRI investigations also determine the entire circumference internal matrix of the bone. And also, when you are trying to do with an MRI, the surrounding soft tissues, which are generally not visible on the conventional radiographs, provides a better information by MRI itself. So the same way the benefits like what the conventional radiography has got on the bones, the same thing also happens down in CT, but you are looking down it in a sectional view. But MRI actually also provides much more information. However, on MRI, we are not going to look at the bones, but we are looking at the surrounding soft tissue structures. The surrounding soft tissue structures are actually the muscles, the blood vessels, and the nerves that are actually forming the giving out the nervous supply. So all of these components are generally evaluated well with an MRI. So you can actually say that both the CT and MRI are much more sensitive when compared down to the conventional radiograph. And they are having superior capabilities when compared down to the conventional radiograph. And if you have to determine, okay, once you have made up a clinical diagnosis, okay, once you have made up a provisional diagnosis and you are trying to prescribe such kind of an investigation, redirect it down towards your problem. Now let's come back to our same three patients, okay, which we have been dealing. Okay, one with the lumbar pain, other one having the wrist pain, other one is having the knee pain, and other one that actually fell down in the uh, fell, uh, fell down in the bathroom. Okay, so we have four cases, and now let's try to determine which of these patients will receive which kind of an investigation. Now, go on. The 13-year-old male, okay, what kind of an investigation do you think is best preferable in this person? CT, X-ray, MRI, which one? Somebody answer it. Okay, what is this 13-year-old male going to get it? X-ray. Okay, that's fine. Okay, what is the 60-year-old female with a knee pain going to get it? What is the knee pain woman going to get it? 60-year-old female with a knee pain going to get? Okay, Rahman thinks it's MRI. Okay, Pratishtha thinks it's CT. All right. Okay, Shabi thinks it's X-ray. All right, so they get X-ray. Two people gets X-ray. What about the lumbar pain guy, the lower back pain guy? What is he going to get? Is he going to get an X-ray or a blood test, or going to get a CT, or going to get an MRI? Okay, MRI, MRI. Okay, what about the 70-year-old female who had a fracture of the femur? Okay, already got a CT there, already she got an X-ray there. So what is she going to get now? She's going to get blood test. Okay, what kind of blood test are you going to do, Rahman? Calcium levels? All right. Okay, I got her calcium level, which seems to be, something around like 7. CBC. Okay, she got leukocytosis. See here, what you need to actually, why I'm asking you all these questions. The reason is actually is that have you formed your provisional diagnosis? Let's come back once again. Okay, the knee pain, yes, you are thinking about rheumatoid arthritis. Yes, the person will be necessary to take down an X-ray because you have to see the joint restriction that is actually happening of this synovial joint there. Okay, and you also are trying to look at the structural capacity of the joint where arthritis only affects the joints problem, right? It actually is creating a joint related problem, okay, which is related down to the synovial membranes, which is also related down to the bone structures. So I'm going to prescribe an X-ray. When I'm thinking about the 13-year-old male who has got a wrist pain, I am going to prescribe an X-ray as well as a blood test related down to his parathyroid hormone because I'm thinking about a clinical condition as juvenile rheumatoid arthritis and also hyperparathyroidism. Okay, I will tell you how we actually came down to a conclusion like that. The lower lumbar pain may not be actually requiring any kind of investigation, but I am going to perform a physical examination first and try to evaluate the extension of the hip joints. Okay, I'm trying to examine the extension of the hip joints and see the pain variation upon flexion or extension of the hip joint and knee. So when I do that, okay, if there is any kind of aggravation of the pain on this physical examination, I am going to prescribe him with an X-ray, because I might be thinking about a lower lumbar pain which is much more frequently coming without any neurological compromise. If there is any neurological compromise, I'm going to prescribe him an MRI on the second hand. Okay, so based upon my physical examination techniques, I am going to determine if he's going to get an X-ray or if he's going to get an MRI. But when compared down to the 60-year-old female who has fell down in the bathroom and having had a femoral head fracture, I am going to prescribe both CT and MRI. Okay, I'm going to determine the CT because I wanted to look at the fracture fragments. Okay, wanted to see how bad is the fracture, and then I'm going to prescribe an MRI to see any kind of neurovascular compromises that is going to happen, which is actually might be called as a compartment syndrome. Heard of this clinical term before? Yes. Have you heard of this one? Okay, compartment, sorry, it's not compart syndrome, it's compartment syndrome. Sorry, compartment syndrome. Okay, compartment syndrome. Okay, I'm trying to look at the compartment syndrome. Compartment syndrome is actually talking about the neurovascular bundles that are actually present in between the fascia. Okay, every kind of a joint or every kind of a appendicular appendages, all of your appendages are actually connected down with muscles, right? There are a lot of muscles. All of the muscles, actually the distributions of the muscles is actually done down as the anterior compartment, medial compartment, lateral compartment, or the posterior compartment, right? So when we are talking about the upper arm, it has got the anterior compartment and the posterior compartment, where the anterior compartment actually forms the brachialis, brachioradialis, whereas the posterior compartment actually has got triceps in it, right? And the same thing actually happens down into your quadriceps femoris muscles. So I am trying to look at different compartments within the fascia and try to see if there is any kind of destruction to the blood vessels as well as the nerves. So I am going to prescribe a CT to look at the fracture components, and I am going to look at MRI if there is any neurological vascular compromise. So whenever there is some kind of a trauma or a fracture, what actually happens is that the blood vessels or the neurovascular bundles are more likely to get destroyed, and they will actually cause a lot of hemorrhage. Okay, and that hemorrhage is actually going to get accumulated in between the fascia of the muscles. Okay, when if it is coming down in between the muscles, it is actually getting restricting that compartmental capacity of movement, as well as it is going to increase the pressure inside that compartment. So, and as a result, there is going to happen a neurovascular compromise, and eventually there is going to happen a condition of ischemia. Okay, it is going to cause ischemia, it is going to cause perfusion injuries in that uh, places. So that's the reason I am going to evaluate for compartment syndrome. Okay, right? And there might be another clinical condition which is also called as necrotizing fasciitis. Okay, Necrotizing fasciitis. I am also going to look for this kind of a clinical condition here, which is actually might be causing an infection if the trauma has been delayed without a treatment for a long time. Okay, so if I can say that there is some kind of a trauma happened, there is a neurovascular compromise on my physical examination, but the patient actually came down to you 15th day after the fracture has commenced, right? So I'm going to look at what kind of infection might be happening, what kind of the compromise that has caused here, which might be also leading down to a condition which is actually called as necrotizing fasciitis. Okay, if you have some time, maybe you try to find out what is necrotizing fasciitis. We will come over when we are talking about the musculatures and other things. Yes, I will talk about this condition, but radiology do not form a lot of a part in trying to evaluate this condition, but there are secondary evidences that you can find on an x-ray. So I'm going to look for compartment syndrome. Compartment syndrome is about evaluating the neurovascular compromise that is happening down in a compartment of a muscle. Okay, musculature in any joint near the bones. Okay, there is a compartment, anterior compartment, posterior compartment, right? The muscles are present down as different compartments. So I'm going to look for a clinical condition called as compartment syndrome. I'm also going to evaluate for their ischemia. I'm also going to evaluate for their structural integrity. So all of those things will be done down on MRI and a CT scan. Okay, so that's what I actually preferred, such kind of investigations for these patients, the 4 patients I have been talking about. All right, and all of them will form different densities. Now you look here, one of the main important rule when you are trying to analyze a CT scan is that you are not going to look at the bones in a soft tissue window. Remember this always. Whenever you are trying to look at the bones, you are going to activate your bone window where your bones will be clearly seen. So you see here, this is a CT scan. Okay, can you take a guess what kind of bone are we looking at here? Though it is written down in the explanation, okay, can somebody tell me how we are going to estimate it? Patella? Okay, we are looking at the proximal femur. That's correct. Okay, what do you mean by compact bone? Every bone has got a compact bone problem. Okay, everyone has got compact bone components. So what is compact bone? Some kind of a bone with a different name? Obviously not, Shubham. Okay, see here we are trying to look at the bone, hip bone in acetabulum. No, where can you actually see acetabulum here, Aman? That's the reason I ask you to know about the structure of all the bones. All right, it will be confusing, it will be a little confusing later on. Okay, if you don't know about the cross section of the bones, or if you don't know about what bone are we looking at, yeah, it might be difficult. See, actually I am looking at the proximal part of the femur. Okay, greater trochanter, lesser trochanter, interesting, I don't find them. Okay, let me show you what exactly I'm talking about. Just give me a minute. See the screen? Can everybody see the screen? Okay, see here. Actually, I have made a cross section of my hip joint, or I can say that I have been coming out from, I have made a cross section from the level of, the pelvis down to the thigh. Okay, when I actually move down slower, you can see here, I'm looking along. This one is the acetabulum. Okay, this one is actually, I'm looking at the acetabulum. And when I am moving down and down, okay, you see here, this one actually became the neck of the femur. And when I'm moving more down and down, actually I can see this became the diaphysis or the shaft of the femur. How can I actually recognize? I'm going to recognize by the compartments that are present here. You see here, this is the posterior compartment, this is the medial compartment, and this is the lateral compartment. So I'm looking at the quadriceps femoris muscle. Now, let's try to look at the other image and try to understand if I'm looking at the same way or not. Okay? See, we'll try to understand if I'm trying to look at the same way or not. Now, you see here, what am I looking at? Now, you see here, what are these things? The muscles, right? These are the muscles, okay? Right? All the muscles are present. Okay, let me try to trace it some kind of a way that, okay, if I'm trying to look at all the muscles like this, does it look something like this here? Yes, no, or does it something look like this here? Which one? Does it look like the upper part, or does it look like something that is different? Actually, I am looking at the level of the proximal part where the acetabulum has been present. Okay, it is the proximal part. Okay, so I'm looking at the acetabular regions and as well as the proximal part of the femur. All right, so that is how I'm going to, differentiate the condition here. So this is actually, you can actually try to look down only in the bone window itself. Okay, when the bones actually look like this is actually called as the bone window. All right, so you can actually see here the 360-degree ovation of the cortex. Okay, the complete cortex is present. Okay, cortex is thick, and then you can actually see that there is a less dense structure that is present down in the center, which is actually the medullary cavity. Okay, so this one is actually, the image is actually optimized to display the bone only, so that the muscles and the subcutaneous fat are less well seen. Okay, so this means to say I'm looking at a bone window. Remember, bones are looked in bone window on a CT. Okay. Now, you see here, I'm trying to look at the MRI scan here. When I'm trying to look at the MRI scan, you have to understand that MRI generally do not display bones. Okay, they have bones. You can actually see the bones, but it is not the true part of the bone that you are looking at. You are not unable to, show up the calcium deposits. Okay, you are not looking at the uh, calcium part of the bone here, but you are looking at the fatty bone marrow component of the bone here. Okay, so there is a difference when you are trying to look at here in the CT scan. I'm looking at the true calcium areas and true medullary areas, but on an MRI scan, actually I'm looking at the fatty bone marrow component. All right, so you see here we are trying to look at the sagittal section of the knee, where the F is the femur and I'm looking at T is the tibia. Okay, right, and then the P, the patella. Okay, all of them. Okay, the three bones of the knee joint actually formed by these, the femur, the tibia, and the patella. Okay, and I'm also looking at, you see here, the quadriceps muscles. Okay, the quadriceps femoris muscle tendon I'm looking at here, and then the patella is the patellar tendons. Okay, you can see here that the quad, how can I actually recognize that this is the patellar tendon I'm looking at? Because the quadriceps femoris muscle is going to get inserted into the patella and finally coming down onto the head of the tibia. Yes, so that is what it is. Quadriceps femoris muscle is getting inserted down through the patella and finally getting down into through the patellar tendon and finally coming down onto the head of the tibia, right? So that is how I know that I'm looking at the quadriceps muscle. Yes, okay, right? You understand? And then I'm also going to look at, you see here, cruciate ligaments, which is actually forming the tangentially passing upon from the posterior side of the femur to the anterior side of the tibula, which are crossing over. So such kind of ligament I'm going to look, and it is actually the cruciate ligaments. So unless I know the anatomy of the joints, unless I know what are the muscles, unless I know what are the tendons that are present around this place, determining and reading MRI might be difficult. So that's the reason I'm asking you to come back and cover with your anatomy, okay? Now, you can actually see here that the signals that are coming down from the knee here are high signals. You see here, this is white in color, so I can actually say this is a hyper intensity or a high signal density that is coming down from the femur. Actually, it is the fat, and you see here, fat is the one that is actually showing up the MRI scan. Okay, it is actually shows up, the fat actually shows up a high signal. Okay, then now you can also see that the cortex of the bone, okay, you see the cortex of the bone has got a weak signal. You see here, water is white, fat contains water. So what kind of an image I'm looking at? I'm looking at a T2WI image of an MRI. You get it? Clear? Yes or no? Right? So I am looking at a T2 image of here because I can see that the fat, okay, and I can see that the bone is black in color, okay, black in the sense if I'm looking at a low signal intensity and I'm looking at fat which is a high signal intensity because it is looking white, so I can make sure that this is I'm looking at a T2 image. All right. So, and I can see the ligaments here. So this is the anterior cruciate ligament. Okay. And this is the quadriceps femoris tendon. And this is the femur bone marrow. This is the patella and this is the tibia. So that is how I'm looking at it. Okay. So that is, don't forget, a CT scan will actually show up only the bone components. An MRI scan will actually show up the soft tissue components. So you should be able to recognize which one is an MRI and which one is a CT, especially when it's coming down to the musculoskeletal system. Maybe at this level, okay, maybe at the MBBS level, you are not going to try to understand all these things, but still the basic thing is that you should be able to recognize which picture is which one. All right? Okay. Now, the next things what we are going to look at is you have the bony trabeculae. You can also have the red bone marrow and the yellow bone marrow. Okay, the red bone marrow actually produces the precursors of soft cells, which is actually necessary for the erythropoietic differentiation. Okay, so erythropoietic cells, all the cells are the one that are present down in the red bone marrow, and then yellow bone marrow, which is actually present down in the cavity, which actually contains only fat. Now let me give you a case scenario. A 40-year-old male has undergone surgery, okay, has undergone surgery to his femur shaft after meeting with an road traffic accident. Okay, there was a complete fracture of the shaft of the femur. Okay, so he has undergone a surgery. Okay, he has undergone a surgery related down to the shaft of the femur. Okay, oh, it's an open surgery. Now, on the third day of the surgery, the patient actually collapsed and the and was suddenly dead. What could be the problem? Okay, let us take another case. The 60-year-old female has got no vascular compromise who has got the fractured neck of the femur, okay, underwent the surgery, again an open reduction in the orthopedic department. On the third day, she starts to complain a lot of dyspnea, okay, a lot of dyspnea. So what could be the problem? Why was the first person dead and what was the second person not dead? Actually, it is quite rude of me to kill a 40-year-old person because of this simple theory, but still, it's fine. Uh, okay, you're talking about fat embolism. Okay, somebody was talking about sepsis. Interesting. Benedict, why do you think it is sepsis? So, are you trying to say that the person died of septic shock here? Dyspnea due to less blood formation. What do you mean by less blood formation? Did I say that he has hemorrhage? I said there is no vascular compromise, right? There is no compartment syndrome, there is no vascular compromise. So why do you think that there is less blood formation? It takes me 120 days to form a new blood if you are talking about that way. So I will be facing my dyspnea after 120 days if your theory actually talks about that way. Shubham. Benedict thinks about its septic shock. Reshma thinks about its fat embolism. How many of you agree with them? See here, the problem to this condition, why the person actually has a spontaneous death after a surgery is will be happening because of fat embolism. On the third day, if it is going to happen, it is because of the fat embolism. But if the person is going to have respiratory distress, yes, it might be happening also due to fat embolism, but the main component it might be happening because of pulmonary thromboembolism. Okay, please give me a minute. I got to take this call. Hello? Huh? చెప్పు ఏమైంది సరే so you understand, you see here the most important and acute complication that is related down to the fractures of the long bones is actually pulmonary thromboembolism. Remember, never ever forget this. Okay, pulmonary thromboembolism is an acute complication that is related down to the fractures of the long bones. All right, because this yellow bone marrow is going to get destroyed and it is going to cause the displacement of the fat that is present down inside the yellow marrow. So it causes fat embolism. Okay, also patients who are undergoing cosmetic surgeries or the bariatric surgery, okay, to reduce the fat reduction surgery or the liposuctions are also are liable to have such kind of a problem. Okay, don't forget it. The most frequent cause of acute deaths after a fracture surgery is going to happen because of pulmonary thromboembolism, and yes, it is also going to happen because of fat embolism. Okay, now you have to also understand one thing when we are talking about the bone marrow is that the composition of marrow is different for different bones. Okay, and the changes throughout the life becomes actually less hematopoietically active with age. So by the age of 30, actually most of the appendicular skeleton contains only yellow marrow, whereas the red marrow resides in the axial skeleton. Okay, can you differentiate me? Actually, we are talking about the axial skeleton and the appendicular skeleton here. Axial skeleton is present down as the vertebral column, the rib cage, and the cranium cavity, right? So that is the axial skeleton. Appendicular skeleton are the ones that are actually forming down your appendages, the upper arm and the lower arm and the pelvis. Pelvis also comes down at a component of the the axial skeleton itself. So you have to understand one thing here, that the red marrow, okay, for the correct determination of the bone marrow problems, you are going to look at only the bone structures that are present in the axial skeleton itself. But when you are trying to analyze a condition that is related down to osteopathic pain, or when you are trying to determine that there is a problem related down to the particularly bones of the appendicular skeleton movement problems, you are going to give an X-ray that is determined for the appendicular skeleton itself. You understand? Now the difference is actually when you are trying to look at the red marrow is present down in the axial skeleton, you are going to prescribe an X-ray that is related down to X-ray or CT MRI, okay, that is determined or reoriented towards the axial skeleton itself, because red bone marrow is present down in the axial skeleton. So now the question comes. I think I have answered this question so many times, so much longer before. Okay, what is the best site of bone marrow aspiration? What is the best site of bone marrow aspiration? Let's say in adults. It's not actually sacral. Superior iliac spine, okay, right? Remember, it is the pelvic bone, okay. Anterior superior iliac spine is the one that is actually the correct area for extracting the bone marrow. Okay, what about a child? If you want to do a bone marrow aspiration, what is the area that you are going to extract the bone marrow from? Posterior superior iliac spine? No. Crest? No. In a child, let's say a child of 1 year, or let's say a child of 6 months, 7 months, something like that, I am actually going to prefer sternum, or I am going to prefer femur. Okay, see, in child, sternum is the most preferable area for finding out the bone marrow. In an adult, it will be anterior superior iliac spine. Got it? Yes. So you can actually should have already understood that these are the components of the axial skeleton itself. Is this clear? Okay, right. Then some textbooks actually also say it's tibia. Some textbooks also say it may be that is related down to the temporal bone also. Yeah, but frequently done is the sternum. All right, if it in a child, yes, you can either go for sternum or either go for femur. Okay. Right. Now, what are the advantages and disadvantages? You can see here, we have already dealt with all this one. You see here, the cortex is the part of the bone, which is most easily visualized on the conventional radiograph. So if you are trying to look at the functional capacity of the cortex, if you are trying to look at the osteoblast, osteoclast functions, all of them, okay, corticomedullary junctions, endocrine physiologies, all of them, you are trying to going to prescribe an X-ray. But unlike conventional radiography, MRI is an excellent means of studying the components of the marrow, a fact that actually makes it much more superior in studying and understanding the marrow pathology. You see here, I think, let me give you a case scenario so that you can actually understand. A, uh, a 80-year-old female complains of a lot of pain, undetermined pain, high-grade fever, serious infections for the last 3 months, a lot of hair loss. Now, she has taken down to a general physician and the general physician actually prescribed her an MRI. What is the disease he's thinking about? A 8-year-old female complains of high-grade fever, a lot of pain, generalized body pains, and she has also been having alopecia. Now, when she has taken down to the general physician, okay, the general physician has actually prescribed an MRI. What is the disease you must be thinking about? That's it. I actually made a complicated case to be very simple, but it may not be exactly like that way, so that you can actually try to understand. That may not be the clinical scenario itself, that may not be the clinical presentation itself, but if I give you much more symptoms, you will try to confuse yourselves. Did you understand my question? Shubham thinks about leukemia. Pratibha thinks about osteoma. Reshma thinks about cancer. Which cancer are you talking about, Reshma? Bone cancer? Possibility. Okay. Actually, I'm talking alopecia. Alopecia is loss of hair. Loss of hair. Okay. Loss of hair. Actually, I loss of hair is generally not seen in cancer unless they are on chemotherapy, on drugs like cisplatin, okay, cyclophosphamide, and actinomycin, methotrexate, other things. Okay, those are the drugs actually that causes alopecia. Cancer chemotherapy, I think if you have look at the pictures of children having cancer therapy, I think you see all of them are completely bald, right? They are bald just because of a side effect that is related down to, you know, related down to cancer chemotherapy. Okay, that will cause alopecia. Lupus, I think you must be watching Dr. House a lot. Every disease is not lupus. Okay? When you can't find a diagnosis, you always say it's lupus. No, Debelina, it's not lupus. Osteosarcoma could be a possibility. You see here, actually, the condition actually I was talking about is the myeloid leukemic syndromes. Okay? Acute myeloid leukemic syndromes. Okay? I'm talking about a leukemia condition. Got it? Well, it may not be complete original case scenario, but trying to understand here one thing is that whenever somebody complains of a deep pain, okay, a lot of pain, deep pain, it can be happening because of bone marrow cancers. It can be happening because of myelodysplastic syndromes. Okay, acute myeloid leukemia, acute uh, leukemia, okay, myeloid leukemias, ALL, AML, okay, all of this one is actually causing undetermined deep pain. But a person, if you are thinking about osteosarcoma, it might be called as an osteopathic pain, okay, osteopathic pain. Osteopathic pain is an entirely different clinical presentation when compared down to the normal pain. Okay, osteopathic pain is felt deep inside the bones where the nerve supply, okay, and you will be literally feeling the pain that is actually it is coming down from the deeper parts of the brain, uh, deeper parts of the bone, but not actually coming down from the superior surfaces. You cannot actually localize the pain. Okay, you can say it, the patient literally says that I can feel that it is deep inside my brain. And yes, when Jabalina says lupus, okay, what kind of thing are you talking about here? Is it systemic lupus erythematosus, or is it something else? Or discoid lupus erythematosus? What are you talking about? DLE, SLE? What is this lupus thing? Anybody heard this name? What is this lupus? Or anybody who watch Dr. House frequently? Yes, they will know about this lupus because it is the one of the, you know, bad diagnosis every time. You cannot explain a disease, you always call it a lupus. Not every disease is lupus. Heard or not heard about this name, lupus? SLE. Yeah, you are talking about SLE here. SLE is systemic lupus erythematosus, okay, which is a condition that is related down to the red blood cells forming the rosettis, which is also frequently shown up as rheumatoid arthritis. It happens in females, and these people actually complain of frequent joint pains. Okay, yes, it could be determined, but actually I was trying to show up a case of leukemia, unexplained fever, but SLE do not have unexplained fever. Pyrexia of unknown origin happens in case of myelodysplastic syndromes. Okay, acute leukemias, all those things, right? So in such kind of a situation, yes, I'm going to prescribe an MRI, which is going to give me a better orientation. Now, right, I think I'm going to stop it here, which is related down to this chapter. Okay, since we came to know about the parts of the bone, that is what actually I wanted to do. But I'm going to complete of the easiest part first, okay, because it is difficult for you guys to understand the increase or decrease in the bone density, which needs a lot of clinical correlation unless and until you are not familiar with your physiological mechanisms and pathophysiologies. Maybe this chapter will be difficult to understand. We will try to complete a very easy part, which is come down to fractures. Fractures are very easy, we can complete it very fast, and it is very easy to understand. Okay, there are not really so much problems that we need to understand here. Okay, so I'm going to continue with fractures now. All right, so this is a very easy when compared down to these metabolism related problems. Okay, I will come back. Actually, I took up that chapter just to give you a better idea when it is related down to the which problem actually talks about which diseases or which modality is much favorable for which disease. That's it. Okay, try to understand, since this is one of the most frequently prescribed x-ray, very often you find a without a skeletal radiograph, a radiology department does not work. Okay, and the most important reason for taking down a skeletal radiograph is related down to pain. Okay, and the pain, most important cause of pain, yes, if it is coming down to physiological diseases, non-traumatic conditions, you can call it arthritis, osteoarthritis, or rheumatoid arthritis, or the inflammation of the bones. Okay, and if it is a traumatic condition, okay, which is met with an accident, trauma is the most frequent, most common reason that is that is actually uh, prompting for a uh, radiographic investigation in a radiology department. In entire hospital, if a trauma patient is coming, you are going to prescribe an X-ray. Even you need not do a physical examination, but first immediately write an X-ray. How many of you guys have had fractures before? Got into a fight, taken down onto a bike, went for a spin. Okay, all you guys, I think maybe at some point of time we should have actually faced out such kind of a problem, fracture. Anybody? If nobody has a fracture, I think you guys are completely non-adventurous. You are completely bookworms. Who are the adventurous guys? Anybody had a fracture before? Yes, Arslan has a fracture. Okay, so we will try to understand the fractures here. So, okay, that's fine. Other guys did not have fractures. You guys are quite good. Yes, you must be careful drivers. But yes, you see here, fractures are and dislocations are the most frequent problems. Okay, anybody had a dislocation before? Now, asking a question, I think maybe the answer could not be direct for this one. What is the most, you know, common fracture that you see? What is the most common fracture that you see? No, I'm not asking the type of fracture. I'm talking about the bone. Which bone? Maybe. Actually, yes, the answer can be, a very, very broad. Okay, the answer can be very, very broad. You can actually say it is related down to the axial skeleton. Okay, sorry, it is related down to the appendicular skeleton. Appendicular skeleton fractures are the one that you see very, very frequently. Okay, right, yes, out of them, it actually depends upon the problems, but actually it is the wrist, okay, the hand bones, or the radius and ulna are the ones that are most frequently seen in a clinical setup. Okay, but it is not entirely, it is entirely dependent on the type of trauma. Okay, wrist joint, but the frequent dislocation, what is the most important dislocation that is frequently seen in a clinic? Humerus does not dislocate. You have to be much more specific. It is actually the shoulder joint that dislocates the humerus. Okay, it is the glenohumeral joint. Okay, glenohumeral joint, which is actually, no, you did not mean that. Humerus is a bone, it does not dislocate. It is the shoulder joint that dislocates, causing the disposition of the, or the transposition of the humerus. Humerus is a bone, joint is a joint. It's different. Okay, so let's try to be more specific when we are writing down on the prescriptions. Okay, humerus is a bone, joint is a joint. So what are the joint I'm talking about? I'm talking about the shoulder joint. I'm also talking about, the other name is the glenohumeral joint. Elbow joint, okay, I think people who come down from India, Pakistan, all these people actually know about these clinical conditions a lot. People who watch a lot of cricket, die-hard fans, you know about these clinical conditions. Is it dislocation? Elbow joint dislocation? It is actually no. Elbow joint actually needs a lot of force to dislocate. But what is the most frequent problem that is seen in an elbow? People who are actually looking at the cricket, they can answer this question. Tennis elbow? So what is this tennis elbow? Is it a dislocation? Or is it something else? Okay, we will talk about those adaptation. What kind of adaptation? Tennis elbow is an adaptation? Yeah, of course, it's a syndrome, but what is this tennis elbow? Okay, we'll talk about this while we are talking about this. Let's not get beyond the topic. Yes, tennis elbow, bursitis. Okay, bursitis, all these things, it is actually forming down the inflammation, yes, to the forearm muscles of the elbow when the cricketer is trying to make down an inner swing or an outer swing. Okay, it can also seen down in the golfers. It is also seen down in the tennis players as well, when there is a sudden extension of the elbow joint. Okay, when you are trying to give a squash, when you are trying to give a crash, when you are trying to make an outer swing. Okay, actually what happens that there will be a sudden extension of the elbow joint, which actually causes the the lateral epicondyle to scratch over the forearm soft tissue, which is actually causing such kind of a tennis elbow, or also called as a golfer's elbow. All right, now, uh, so elbow dislocation takes a lot of energy unless you actually hyperextend with a lot of blunt force. When you directly hit on the elbow with a blunt force, Unless other than that, it is not actually going to cause any kind of dislocation. Okay, so humerus is the one it actually tries to dislocate more frequently. Okay, the other one, where else dislocations can happen? Hip joint, vertebral discs. Yes, absolutely correct. It is going to be the vertebral, intervertebral discs that are going to dislocate more frequently. Knee joint, no, it takes a lot of force to dislocate the knee. No, I'm talking about minor injuries here. I'm not talking about the greater, bigger injuries. So that's the reason when it is a minor thing, and that is the reason it is actually frequented down into a hospital. Okay, that's fine. We will ankle joint. Yes, ankle generally do not dislocate. Ankle actually, twists it, actually causing the inflammation there. Okay, ankle generally do not dislocate. Yes, it also needs a lot of force. Ankle joint is a sustained joint. Knee joint, yes, it has got a locking mechanism which does not dislocate frequently either. But vertebral discs, intervertebral discs are the ones that are going to actually get dislocated. And humerus, the reason why the humerus is going to get dislocated very frequently because it has got no joint connections in the inferior side. Okay, anterior inferior side, it do not have any kind of ligamental connections. Okay, where you have the glenoid capsule, right? Okay, glenoid capsule and the glenohumeral ligaments that are actually coming down, they are not covered down on the anterior side and the inferior side. So that's the reason anterior dislocations of the humerus shoulder joint are more frequent, and it will be happening because of the hyperextension when trying to prevent the twist of a person. Okay, for example, to say, let us say when I'm trying to trying to climb a ladder. All right, when I'm trying to climb a ladder and I slipped my hand, slipped my leg. When I slipped, I'm trying to fall and I'm trying to prevent the fall by holding on one side of the ladder, and that side is going to get dislocated because I'm going to make an hyperextension or the forceful external rotation of the humerus. So it is going to twist anteriorly and there is going to dislocation. Okay, you understand this? You will learn that in more when orthopedics comes over, but try to understand, remember that thing. Anterior inferior dislocations are the most frequently seen in shoulder joint. Okay, knee joint, no, it requires a lot of force to uh, dislocate the knee joint because it has got a locking mechanism. Ankle joint, no, it also is very well secured from the talus bones, so that's the reason it is also requires a lot of force to dislocate the ankle joint. Elbow joint, the same way, it has got the locking mechanism as well, unless there is a lot of force that is causing the hyperextension of the elbow joint, or a direct blunt force trauma from the volar aspect is going to give you the elbow joint dislocation. Okay, so they are not so frequent. Is this points clear? Fingers, okay, no, fingers are the ones that are not going to dislocate very easily. Okay, wrist joint, well, in children maybe yes, but humerus is the one you see here. Actually, you need to understand one thing here. Whenever such kind of a peculiar joints that are going to dislocate, it is actually happening because of the action dynamics. Who watches action movies? Who is a fan of Jackie Chan and you know these Fast and Furious type of movies, Vin Diesel type of movies? Okay, you have this action choreographer, right? Stunt choreographers, action managers, right? Happens, right? See, unless and until we understand the action dynamics, okay, unless and until we do not understand the action dynamics, how the accident has taken place, maybe you cannot technically say which joint has been dislocated. Okay, so whenever you are trying to understand a fracture or a dislocation, it is very important for a person to know about the action dynamics. Okay, um, I don't know if you have covered these all things uh, in forensic medicine. Yes, no. Have you covered this action dynamics part in forensic medicine? There are so many rules and regulation. What happens? What are the steps of an accident? No? Okay. Maybe I will try to talk about them only if it is necessary. But you have to know about that. It is a very important chapter. Action dynamics, ballistic injuries, that is related down to road traffic accidents are related down to ballistic trauma. There are so many rules and regulations that are theoretical information that you need to remember to understand the kind of trauma. Okay, because it is always remembered, never ever forget in your whole life, a doctor who cannot diagnose a fracture is liable to get penalized under the court of law. Okay, you cannot misdiagnose a fracture. You cannot you know neglect a fracture ever. Okay, remember your whole life. If you are missing a fracture in your body, in your patient, in your body or in your patient, you are going to get penalized under the court of law. So a radiologist, a physician are at risk. So if you are suspecting a fracture, make sure that there is no fracture. So the first rule in radiology is that I'm talking about the quality assessment and I'm trying to talk about the fracture assessment here. Okay, remember and listen carefully. Okay, whenever you are trying to take a joint x-ray, I will come back to this part once again, but first try to understand the quality assessment first, then we will talk about the fractures. Okay, remember the qualities first. Right, how you are doing to try to make an assessment that is related down to the quality of the abdomen x-ray. When you are trying to determine the quality of a chest x-ray, there is also that some rules and regulations that is related down to the skeletal x-ray. Okay, this is not present in these slides, but it is not actually, it has been removed from your syllabus, but still I will try to give you because it is going to help you in your clinical practice a lot. So if you have notes there with you, try to write down what I'm talking. All right, remember, a skeletal system x-ray, whenever you are trying to analyze a musculoskeletal system radiograph, you have 6 rules to follow. Always remember. Okay, 6 rules to follow. I will be uh, either you note down, okay, because it takes a lot of time for me to type them on. Okay, the first thing, whenever you suspect a fracture or whenever you suspect there is a problem related down to the musculoskeletal system, a joint, okay, you have to involve the symmetry. Okay, let us say a patient came up with a right hand joint pain, okay, right wrist hand pain. You are not going to look at only his right hand, but you are also going to look at his left hand as well, because comparison of the symmetry is always important. Okay, so when you are trying to write a prescription, you are going to say that I am going to look at both of your hands. Write in the prescription x-ray hands, not only right hand, left hand, unless you know what you are looking for. Okay, so always compare your x-ray with symmetry. First rule. Okay, rule number 1, please take a list of all these rules. Okay, it will be very helpful for your clinical practice. Yes, are you guys following me? Yes or no? Okay. Now, the second rule is the second. I will tell you the reasons why, but let me repeat. Okay. Whenever you are trying to look for a problem related down to musculoskeletal systems, always try to prescribe the X-ray of the joint that is in of the uh, appendage or the bone that is involved, and also try to prescribe the symmetry. For example, to say I have a problem on the right hand, also try to prescribe an X-ray if necessary of the left hand as well. Get it? I have a problem on right wrist. Okay, other than prescribe or also prescribing the right hand, if doubtful, also try to prescribe the left wrist joint as well. Okay, yes, Benedict, is this clear? So rule number one, include symmetry. Include symmetry when you are trying to look for musculoskeletal systems. Okay, yes, yes, Benedict, is this clear? Always look for symmetry and try to include symmetry in your prescription, because it might be helpful for a diagnosis. I'll tell you when we are talking about diseases more. Okay, right? Do I still need to repeat it? Okay, the second rule, never ever take a skeletal system radiograph only in one view. Okay, it means to say you have to prescribe a skeletal radiograph in multiple views. A single view is not enough. For example, to say when I'm trying to look at the chest, I'm trying to only write a PA view. When I'm trying to look at the abdomen, I'm just going to write only AP view. But when it comes down to the skeletal system, you cannot just say PA view and is enough. No, you have to write a AP view and lateral view, and if necessary, sometimes axial view. Okay, you have to prescribe a musculoskeletal system radiograph in multiple views. And the same thing applies for the symmetry as well. Okay, you are suspecting a problem in the right hand, but still the right hand you are unable to diagnose the problem even after looking down at the AP lateral views of that right hand. Okay, also do repeat the same thing when related down to the left hand as well. Okay, so you got 4 X-rays. Get it? You got 4 X-rays. What are the 4 X-rays? AP right wrist, lateral right wrist. Okay, left AP right left wrist AP view, lateral view left wrist. That is what 4 images you got. 4 images. It is expensive, but still you have to write it no matter what, because it's not about making money here. Don't ignore, guys. Okay, you are not going to make money here, but it is actually going to give you a lot of information. When you are trying to look at the bones, you cannot look at the bones only in one view. You have to look at in different views. We'll talk about it in fractures. Okay, this is always necessary when you are trying to analyze a problem related down to musculoskeletal system, especially for fractures. You have to prescribe in multiple views. The rule is prescribe in multiple views, and the views are generally AP view, lateral view, and axial view. Okay, right. The third rule is whenever a skeletal radiograph is taken, okay, whenever a skeletal radiograph is taken, if it is related down to the joints, first try to understand, then I will tell you the rule in a single sentence. Whenever you are trying to look for a joint pathology, okay, whenever you are trying to look for a joint pathology, for example, to say here I'm looking at the wrist joint. You see here, you have to include the bones proximal to the joint and distal to the joint. Okay, understand? whenever you are trying to analyze a problem for a joint, in the radiograph, you should always include the bones, the anatomical relations, okay, the anatomical bony relations proximal to the joint and distal to the joint. It's always necessary, okay? Include, okay, in case of joint x-ray, always include bones present proximal to the joint and distal to the joint. That is the rule number 3. Get it? So the same rule applies when you are taking down for the other symmetry as well. Understand? Yes or no? Okay? We'll talk the reason once again why we are doing this one, because it is going to help us diagnose the conditions in a better way. Okay, rule number 4. When you are trying to look for the bones, okay, when you are trying to look for the bones, make sure you are going to include the epiphysis, the metaphysis, and the diaphysis at least one particular end. Okay, when you are trying to look for the problem related down to physiologies of the bone, at least try to include the epiphysis, metaphysis, and the diaphysis, which means to say I am going to take the x-ray of the whole bone. So all the bone should be present. It means to say the proximal end has got proximal epiphysis, the distal end has got distal epiphysis, which means to say I am taking an x-ray of the whole bone. Okay, right? And at the same point of time, in that situation, include either the one joint present proximally or the joint that is present distally. When I'm trying to analyze a bone, okay, when I'm trying to analyze a bone, I have to make sure that the epiphysis, the metaphysis, and the diaphysis of the bone is included in my x-ray, okay? And also I'm trying to include one joint either present down in the humerus, one joint that is present down proximally or one joint that is present distally. For example, to say, when I'm trying to look at the radius and ulna, okay, when I'm trying to look at the radius and the ulna, I am going to either include the wrist joint or either I am going to include my cubital joint, elbow joint, okay? Or let us say when I'm trying to look at the femur, okay, when I'm taking the x-ray of the femur, I'm trying to include either my knee joint in the x-ray or I'm going to include my hip joint in my x-ray. So generally they include the proximal joints that is present, okay? For example, to say when I'm trying to look at the humerus, they will be including the glenohumeral joint or the shoulder joint. But when they are trying to look at the radius and ulna, they are going to look at the elbow joint, okay? When they are trying to look at the femur, they are going to look at the hip joint, they are going to include the hip joint. When they are going to look at the tibia and fibula, they are going to include the knee joint. When they are going to look at the tarsals or the metatarsals, they are going to include the ankle joint. Is this point clear now? Okay, when you are trying to look at the bones, include the proximal joint into the x-ray. Perfect. Rule number 4. Then rule number 5, the same thing. Then again, all other rules has to be satisfied. Yes, it has to be taken down in multiple views. Yes, it has to be compared down to the symmetry whenever it is necessary. Okay, whenever it is necessary, you always have to look for previous radiographs. Okay, whenever you are going to look for previous radiographs, you are also looking at the symmetry, you are also looking at the previous radiographs. So whenever it is available, compare the films, the current investigation, today's investigation, to the previous radiographs. So multiple investigations may be necessary. Okay, for example, to say I am going to look at today's x-ray and compare it to the x-ray that has been taken 15 days ago. So x-rays taken at different times, multiple time x-rays, okay, multiple investigations, okay, you always need to compare. Doesn't matter if you are looking for a joint, if you are looking for a bone, always compare it to the previous films. Okay, right? You're not even you need not ask about history here. Your film is your history. All right, so look at the previous films whenever necessary. Okay, is this point clear? Rule number 5 completed, right? So rule number 6. Okay, rule number 6: whenever you suspect a pathological condition, okay, whenever you suspect a pathological condition, you have to go and determine and confirm the pathology on a higher modality. Okay, for example, to say I am suspecting, you have to confirm the diagnosis on a higher modality. For example, if I'm trying to look at the lumbar disc prolapse, when I'm trying to look at the problem that is present down as spondylitis, when I'm looking at the disease called as spondylolisthesis. Have you heard these terms? Spondylolisthesis. Yes, spondylitis. Yes, okay. So you have to confirm such kind of a diagnosis on a higher study. For example, to say it might be difficult in some kind of physiological conditions. So, for example, to say I have a disc prolapse. So, I have taken down an X-ray of the lumbar spine. Okay, I have taken down the spinal X-ray. So, what actually happens is that I found out that there has been some kind of a structural orientation that has been lost. The lumbar lordosis has been lost. So I came to understand, yes, maybe, and also when I have done the physical examination technique, I am suspecting a disease like spondylolisthesis or spondylitis. So I am going to confirm my diagnosis on a higher modality. So what is the higher modality that is related down to this one? Spondylolisthesis, I am talking about the intervertebral discs. So what is the best investigation for intervertebral discs? It is going to be an MRI. So I am going to confirm this kind of a pathology that is present down on the higher study. You get it? So there are 6 rules of prescription of a skeletal radiograph. See, generally they won't teach you all these things unless you come down into the clinical practice. But they have removed of these rules and regulations a long time ago. But you see here, the only reason is that, okay, it comes down through clinical experience and practice that you will spontaneously know, arbitrarily know all these conditions. You will know about these rules and regulations in no time. It is very easy to remember these things. But if you are not giving concentration down to these problems, every skeletal radiograph is going to cause you a misdiagnosis. You understand? The reason why I'm telling you these clinical determination factors, whenever you are trying to prescribe any kind of imaging investigation related down to the musculoskeletal system, do not ever forget these prescription protocols. It is always very important. Do you want me to repeat the 6 rules once again? Okay. Yes. Is this points clear? All these guys clear? Okay. Do you want me to repeat it for other people? Okay. Yes. Okay. I'm going to just repeat only the rules. Okay. I'm not going to repeat the explanation, but I'm just going to repeat the rules. Okay. Always include symmetry. Always include symmetry whenever it is necessary. Okay. So if you are trying to look for right hand, left hand is to be included if it is necessary. So always include symmetry. Rule number 2: always prescribe multiple views. always prescribe multiple views. A musculoskeletal system radiograph has to be uh, you know observed in multiple views. Okay, the most frequent multiple views are the AP, lateral and axial views. If it is necessary, always prescribe, no, it is always compulsory. Skeletal system radiograph has to be done in multiple views only. Okay, don't even just only prescribe one view and stop it off. Okay, rule number 3, when you are trying to look at the joints, always include the bones that are present proximal to it and distal to it. Include the bones that are present proximal and distal to the joint. Always necessary. Always include the bones present proximal and distal to the joints. Okay. And then rule number 4. Always include the epiphysis, metaphysis, and diaphysis along with the proximal joint. Okay, rule number 4, always include the proximal joint, epiphysis, and the metaphysis and the diaphysis of the bone. Okay, rule number 4, right? Then rule number 5, always compare your skeletal radiographs to the previous studies. Always compare your radiographs to the symmetry and the previous studies. Always necessary. Then rule number 6, confirm your diagnosis on a higher modality. Confirm your diagnosis on a higher modality. Perfect. Okay, all the 6 rules. This, do not ever forget these rules in your clinical practice. Okay, now let's try to take an example and see why it is necessary when we are trying to look for a patient in a trauma or any kind of musculoskeletal disorder, where we have to know why is it necessary. Okay, is this clear, guys, now? Yes, right? Please do not forget these rules, because whenever you cannot see such kind of an x-ray, it is going to give a misdiagnosis. Let us see how. For example, okay, okay, in this fracture chapter, what we are actually going to do is that we are going to look at the fractures, types of fractures, and different fracture action dynamics, and then we are going to look at all the joints. Okay, we are going to look at all the bones. Okay, and try to learn about their fractures. Okay, in a broad way. Right now, first see here. Okay, I'm trying to look at here. It is a very simple thing. Okay, a fracture is the discontinuation of the periosteum. Okay, the definition of a fracture clinically comes down: discontinuity in the periosteum of the bone is called as a fracture. Okay, when the periosteal membrane is disrupted, disturbance, disruption is caused. Okay, it is called as a fracture. So disruption or disturbance created in the periosteal layer of a bone is actually called as a fracture. Disruption of the component, and it doesn't mean that it has to extend from one end of the bone to the other end of the bone. Did you understand why I'm telling you this? Fracture is a fracture. Cortex, even it should not be included the cortex at all. You just see that there is disruption of the periosteal layer on a skeletal radiograph. You can just call it as fracture. Understand? Yes? How many of you people did not understand this point clear? Discontinuity or disruption of the periosteum is called as a fracture. Yes? Is this point clear, guys? Okay, let me show you how. You see here, while we are trying to look at an x-ray, you see here, I can actually see that when I'm trying to look at the the cortex of the radius here, you can actually see that there is a discontinuity in the periosteum. Discontinuity in the periosteum, rather than having a single line, there is a discontinuity of the periosteum on the medial side. So I came to understand, oh, maybe this is a fracture. So this is an absolutely a fracture. So that is more than enough. It actually come, you need not, even the fracture line should not go from here to here. It need not extend all the way. Okay, a complete dislocation, a complete, you know, separation of the bone need not happen to call it as a fracture. Okay, just a discontinuity in the periosteum is called as a fracture. Simple. And always remember, a fracture appears as the discontinuity, and a discontinuity will appear as a black line. Okay, so how can I actually define fracture in radiology? I can define a hypodense line seen as an evidence of disruption or discontinuity of a periosteum is actually called as the fracture. So how is it? It is a hypodense line. Okay, it is a hypodense line, or it is a radiolucency. Now tell me in this one thing. Okay, let me give you a random image and you tell me where exactly is the fracture. Okay, I'll give you a random image first and then you tell me where is the fracture. All right. Just let me find an x-ray. Let me find. Just give me a minute. Okay, take a look at this radiograph. Take a look at this radiograph and tell me where is the fracture. That's a quite easy picture though, but you tell me. Or maybe let me make it a little harder. You keep on typing the answers. Okay, I'll check it out, but let me find out. Okay, little finger. So many people saying thumb, 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 and Reshma thinks it's little finger. What is this little finger? Okay, who can tell me the scientific names of all your fingers? Phalanges. Really? First phalanx, second phalanx, third phalanx, fourth phalanx, fifth phalanx? That's what it is? There are some names to that. Okay. Try to look at this x-ray and tell me where is the fracture. or else see this actually it is for only for practice and for now, okay, but we will talk about more things. First, let us try to understand how we are going to define a fracture, to recognize a fracture. That's what we are going to practice here. All right. Okay. Lower part of fibula. You see here, see, try to make sense when we are trying to tell some kind of a word like that. Okay, let us try to be more, okay, let us try to be more scientific. You can actually say it is the distal diaphysis rather than saying it as the lower part of the, okay, lower part. Rather than saying lower part, you can say it is the proximal end of the tibia. Arslan, you find it in the proximal end of the tibia. So you don't know which obviously is the proximal end and what is the distal end. Okay. See, no, Aman, that's what I have been telling. You cannot point out the fracture only on one image. Point out the fracture on both images and confirm it. You get it? Patella in upper picture. You see patella too in upper picture? Let me check, please. Where? Patella? Did you see patella there? I don't see patella there. I don't see patella there. You see here, it is taken, this picture is actually taken down in, I can say something around like in 2016. Okay. In 2016, it means to say this is a 5-year-old person. So what are the patella are you talking about here? Tibia, ankle. See, patella in upper picture. Devendra, where did you see the patella there? Can you point it out for me? Distal end of the tibia. You see here, doesn't matter what kind of a x-ray you are looking at, a fracture will look as a hyperlucent or a black line, which is recognized as the discontinuity of the periosteum. Did you understand this? Is this clear now? But you see here, when you look closely, okay, let me give out a part of this part, this thing. Let us try to zoom in and see. Now, do you think that this is a fracture here? Can everybody see the screen? That's what I'm saying. You see here, that's what the confusion part is. Exactly. Devendra, I know most of the people would talk about this one. Okay. I said always compare. Compare to the symmetry. Yes or no? Right? So when you are trying to compare it to the symmetry of the bones, right? Now try to look at all the bones. Try to look at all the bones that are present down here. Okay, since Devendra is talking about this one here, okay, I need to compare it to the symmetry, right? Symmetry of individual bone also has to be compared individually, also compared to the other side as well, right? Either you are comparing the symmetry as proximal to the distal, okay, or either you are comparing it to the superior to the inferior, medial to the lateral, or something like that, right? So now you see here, you are trying to include the epiphysis, metaphysis, and the diaphysis. You see here the line, the hyperlucency, the line I'm looking at here is not a fracture, but I am looking at the epiphyseal line, which is not yet ossified, because this is a child. So that's the reason I wanted you to learn the anatomy of the bones first, so that you can actually come over again. You see here a hyperlucency that is seen immediately after the epiphysis of the bone is, and here is the metaphysis, right? Metaphysis is the continuation of the Metaphysis is the continuation to the diaphysis, right? It is continuous. There is no separation between the metaphysis and the diaphysis. But there is a discontinuity that is present down between the epiphysis and the metaphysis, which is appearing as a hyperlucency that is shown symmetrically. Okay, it is present also on the proximal end. It is also present on the distal end. So it is non-ossified. Exactly, that is what I'm saying. You need to know about the ossifications. You need to know about the ossification centers. Which bone gets ossified at which time? That is the one is actually going to say. That is the one why we are talking to compare it to the symmetry. Even if you don't know about that one, the rule of symmetry talks, okay, and you can see it. If it is present down all the parts, okay, everywhere, it is present everywhere. You see here, it is present also on the proximal side. It is present also on the distal side. So by this, actually, I can understand, yes, it is symmetrical, which means to say it is non-ossified bone I am looking at, which means to say I am looking at a child. But if you look at the date of birth here, it is 2011, which means to say it is a 5-year-old child and ossifications did not complete. Right? So ossification of the long bones happens. Patella ossification. Okay, find out the ossification of patella. When does it happen? Anybody have an idea? It's true. But why can't I look at here? Actually, this X-ray is not including for the patella because I'm not able to look at the patella because I have only taken AP view. But the problem here is this is both the AP view and the previous films. Okay, actually I am comparing. This is before, this is after, and both views are same. Get it? I am comparing here for the fracture healing. In this picture, I am comparing for the fracture healing with the previous radiograph. So this is today's radiograph and this is the previous radiograph. You see here when I'm moving close enough, okay, when I'm moving close enough, can you see a very, very thin line here, which is a hyperlucent? Okay, and you see here there is a discontinuity of the periosteum, a little disruption of the periosteum here. Yes, but when compared it to the film on to the left side, you see here that is gone, which means to say my fracture has been completely healed. So compare it to the previous films, always necessary. Did you understand now? Yes, I know the diagnosis here. I came to understand that this is a fracture. So what I'm trying to do, I'm looking it in one view. Of course, I will do the same thing in its lateral view also. Okay, I will also do it in lateral view, but still, why I'm looking at here, when I'm trying to look at here, I am comparing with the older film. So this is the older film. The film on to my right is the older film, and the film on to my left is the newer film. So I am looking for the healing process that has occurred in the fracture. So you see here, there is a lot of discontinuity of the periosteum here, but you see here on compared to today's image here, this is much more better. It is completely ossified, which means to say the patient's osteoclastic function has happened before, and now the osteoblastic function has also happened, right? So I can understand that the fracture healing was successful, right? Yes? Is this clear? Okay, now what about the other films? What about the other film? Here, okay, the fracture is present down here in the distal end of the, is it tibia fibula? See, Aman, that is the problem here. When you are trying to show it only on one view, can you tell me, is it tibia or the fibula? You cannot, right? See, because it is overlapping shadows, I don't know if it is tibia, I don't know if it is fibula. So how I'm going to do? I'm going to look at, remember this shadow, and I'm going to look at in the other film, okay? And try to understand if it is, okay? And try to understand if it is a tibia or a fibula, okay? Just give me a minute. I think it's downloading. Just a second, please. Okay. All right, you see here, this is the AP view of the ankle joint. Okay, this is the AP view of the ankle joint. In the AP view of the ankle joint, I can see that there is a fracture that is present on the distal end of the tibia and the fibula, both. You see here, this is the tibia and the fibula, this is the fibula, okay, and this is the tibia. How can I recognize it? I can recognize it, but the fibula is present down on the lateral side, okay, and this is the tibia. So you see here, there is a fracture that is present down on the fibula distal end, right? And here I can also see that there is a fracture that is present down on the medial condyle of the tibia as well, okay, distal medial condyle of the tibia as well. But in the lateral film, I cannot see that there is a fracture of the tibia, but I can see that there is a fracture of the fibula. See, so that's the reason. If I have been looking only on this one, I would be missing out the fracture that is present down on the tibia. Is this understood, Aman? I have missed a fracture, okay, right? So you have to compare it on both the views and compare the diagnosis on the both the sides, because you see here there are two fractures. One fracture is present down on the tibia, one fracture is present down on the fibula. So fibular fracture and the tibial fracture, and there is a there is a mild anatomical disorientation of the ankle joint. So such kind of a fracture is actually called as the Volkmann's fracture. Remember, okay, this kind of fracture is actually called fracture. Okay, remember, please show me the borders of the tibia and fibula. What do you mean by borders of tibia and fibula? What do you mean by that? What borders are you talking about? Which you don't understand which one is tibia and which one is fibula? Okay, you mean to say which has fracture? Okay, I understand. I understand. Just a minute. Okay, you see here, in which view don't you understand? In the lateral view you don't understand, or in the AP view? Which one? Lateral view. Okay, all right. Okay, see here, when I'm coming closer, okay, when I'm coming closer, you see here, this is the tibia, okay, this line comes down along with the tibia, okay, and this line is the fibula. Perfect. Okay, right? So the end is the, this one I'm trying to look at. Okay, sorry, just a second. Okay, this one actually is the, I'm trying to look at the component that is present down here. Okay, so this is what I'm looking at on this lateral side here. Okay, because it is present immediately above the talus, and you see here it is anteriorly dislocated. See, this component, this fracture part is anteriorly dislocated. It's moved anteriorly. See, I can see it much more anteriorly. Yes, Hisham, were you able to follow? Yes. What about other guys? I think you have the same kind of problem. Did other guys were able to understand? Okay, so it's the fibula. Okay, so it's the fibula. Yeah, true. Okay, then when you are trying to look much more closer, okay, when you are trying to look much more closer, okay, the problem I cannot see here is I cannot see the tibial fracture here, but I can see the tibial fracture which is present down only in here, right? See, I can see the tibial fracture only here. So this one is here and this one is here, right? Okay, so such kind of a fracture, distal end of the fracture, distal fractures of the tibia and fibula with internal rotation of the ankle joint, okay, or with the mild disorientation of the ankle joint is actually called as a workman's fracture. Remember, all right, so this is a workman's fracture. Now, did you understand why we are trying to look it on lateral views? Because you will be able to miss out the fractures in just if you are looking at it in one view itself. So multiple uh, views has to be taken. Compare it to the previous radiographs, okay, to see the healing processes. And then last one, you see here, this is the AP view and the lateral view. This is the AP view and the lateral view. I am trying to look at the, what is this thing? It's the thumb or is it the little finger? Who told its little finger before? Okay, it's the Reshma. Once again, you are saying little, little, little. It's not the little finger. Okay, see, it's not the little finger. How can I know it is the little? How can I know it is not the little finger? Because this is the radius. Okay, this is the radius. Okay, on the radial side you have the thumb. On the ulnar side you have the little finger. Yes or no? So that's the reason it has got a problem. Yes, of course, it has got two phalanges. That is true. But sometimes what will you do if he has got a three phalanges, right? Something like a Hrithik Roshan, okay, who has got three phalanges, extra phalanx. So what are we going to do? Brachydactyly, polydactyly, if you have a problem with that one. So how I'm going to determine? That's the reason I say that include a joint and include at least the bones that are present proximal and distal to the joint. So how can I know? On the radial side, this is the radial side, continuous with this one. On the radial side, there is the thumb. On the ulnar side, there is a little finger, right? So that is how I recognize. So that's the reason always include, okay, always include at least the bones present proximally and distally to it. Always necessary. You understand? So if not, you see here, if Reshma could have diagnosed it as the little finger, she will be operating on the little finger, but still the problem is present down on the thumb. Did you understand? It's the biggest mistake done by a doctor. Yes? Is this clear? Okay, and you tell me if it is a right hand or a left hand. This one, right hand or a left hand? Is this right hand or left hand? How can I know it? How can I know it? How do I know it's right? How do I know it's right? Because on the always the thumb goes down to the medial side. Okay, right? The thumb on in supine position, how it will be? Okay, the thumb is present down on the lateral side. But when we am taking down the wrist X-ray, I am actually doing it in supine position. And in in supination. When I'm trying to do it in supination, the thumb actually goes down onto my medial side. When the thumb is coming down onto my medial side and it is present onto my left side, so which means to say obviously I'm looking at the left hand. Yes or no? Sorry, I'm looking at the right hand. Yes, thumb present down onto my left side, which means to say I'm looking at my right hand. Yes, is this clear? So don't even again make a mistake and say that yes, this is a left hand, because rather than operating on the right hand, you will be operating down on the left hand. You see here, there is no even view that is present down here. So that's the reason I am asking you to learn the anatomy of all the bones in all different directions. Open down your Netter Atlas, look at the bones in different directions. If you have a 3D anatomy software, look it in 3D anatomy software and look it in different directions. If not, this whole fractures chapter, whole musculoskeletal system is going to be very difficult. All right. So I think that's it for today. Okay, we will complete our fractures tomorrow. All right. So we're going to close our session.